Hello and welcome to Sheila Lives Out Loud. I'm Sheila Moniga and I'm thrilled you found this channel. Please click subscribe and hit notifications so you never miss an episode when we upload. And over the past couple of weeks, we've been uploading conversations with diverse personalities as we go through the COVID season. That hasn't changed. The lockdowns or lock-ins continue in several counties across Kenya, and we're doing our best to keep each other motivated, engaged, and most importantly, informed. And joining me for another session, I think Dr. Simon, the Secretary General of the Kenya Medical Association, was the very first guest to speak to us on COVID-19. Doc, it's so wonderful to see you, Dr. Simon Kigondu. Sasa?
Very good, very good. Always a pleasure to be heard by you.
Oh, wow. It's wonderful to see you. I think it was about 10 weeks ago that we had our first conversation, maybe 8 weeks, 10 weeks, something like that. It's unbelievable how quickly time flies, Doc. But here we are.
Yeah.
Excellent. Now, in this time, there's a lot more information. I want to believe the population knows a lot more now than we did 8 weeks ago. But the conversation I'd like to have with you is really primarily centered on the way forward. Knowing what we know, what has changed so far?
Yeah, Sheila, thank you very much. And as you can see, life is changing because of how unsure we are about the direction that this COVID-19 is taking us. And we are having daily press briefings, so to speak, by the government. There are some areas in the country where movement has been restricted. And there's actually no lockdown in Kenya. Kenya has what is called movement restrictions. Some countries abroad, like Spain, actually had a lockdown. A lockdown would mean you actually don't get out of the house. But Kenya had chosen more of restriction of movement rather than a lockdown. So I think what we are trying to adopt to is the new reality, whereby COVID-19 has actually now moved to community transmission, which was what we were trying to avoid initially by ensuring that every traveler is quarantined, they have no issue. But now, the horse has bolted. There is actually community transmission. Community transmission means that COVID-19 is among the population and it is actually spreading among the population.
There's a lot more information, but we also have a lot more cases now. Like you said, initially it was about the travelers, but now it's come down to community transmission. We remember headlines. Some of them were very, very scary. I remember a newspaper projection that said 10,000 cases by the end of April. Looking at those projections and what's on the ground now, was that just sensationalism, or is that where we're now headed as a nation?
Every country has its own way of dealing with COVID-19, and this depends on what are the structures in place within that country that would protect the population from the adverse effects of COVID-19. And it has boiled down eventually to healthcare. So what is our biggest fear? Our biggest fear is that someone who gets COVID may go into the classification of severe disease, will need some form of healthcare that may not be available to them. And they may end up dying because that healthcare is unavailable. So that being the case, we chose a path of actually preventing people from actually getting the disease and people from transmitting it. And therefore, our path of doing what are called movement restrictions, identifying, isolating, and trying to manage those only who have the disease was our pathway. if, for instance, the aim of that is to prevent the hospitals or the healthcare systems from being overwhelmed. If the hospital systems are overwhelmed, then you start getting people dying from other diseases other than COVID, because COVID-19 people are in the hospital. So where we are at now is that we were not able to prevent community transmission, because when the first case came to Kenya, there was no COVID-19. The infection was not within the community, but as time went by, then community transmission came. So currently the situation is that there is community transmission. We are still trying to limit the number of people getting the virus by various measures in what are called hotspot areas. We are also now trying to identify, our strategy is to identify, isolate, and ensure that they have healed to avoid transmission to other people.
Right.
That's where we are.
Okay, so there is progress. I'd like to believe we're testing a lot more individuals now, because I think earlier on, when everything was up in the air, well, it's still all up in the air. But in the beginning, there was a question about the test kits and where we could find the test kits. And I think there's a lot more testing now. If anything, I think last week we had a day where we saw triple-digit numbers in terms of cases that were found positive. About how many people are being tested every day, and can we step up that capacity?
We have actually seen that the laboratory systems of Kenya have improved from day one till now. We have Cambrian National Public Health Laboratories labs taking the lead. And the main issue was the unavailability of the test kits, and also availability of the swab to take the kit. And apparently, these are all, in quotes, made in China. But our labs have stepped up their game. And in some of our meetings that we have as the Kenya Medical COVID-19 Advisory Committee, we have actually received presentations from Dr. Matilu Mwau of Kemri, and they said they have upped their ability to actually do these tests. And with time, we have seen that more tests are being done, and more machines. They are trying to adapt more machines to do these COVID-19 tests. And the difficulty of this test is that it's a PCR test, what we call a polymerase chain reaction test, which actually looks for the virus. We haven't reached the stage where we are doing immunological to check whether people have become immune. We're actually looking for the virus so that we can isolate these persons, so that when they get better, then they can go back to the community so that they don't have to transmit the infection. So the lab capacity in Kenya has actually increased. And you may have seen recently that more and more tests are being done. Therefore, they have done a good job.
Okay. Earlier, I think about a week ago, I also conducted a small poll on my Twitter handle to find out whom amongst us is willing to take the test, because a lot has been said about quarantine facilities, about actually willingly taking yourself to the test and dealing with the repercussions of actually saying, I've taken the test and I'll, live with the results, whatever they may be. And in asking individuals whether they were ready and willing to take the COVID test, 43% of respondents said they would, 42% said they wouldn't, and 15% said, I don't know. And we can understand the fears that come with testing, but I'd like to believe that other than just the contact tracing, you're testing a lot more individuals who are willingly stepping up and saying, yeah, please check. Maybe nina shuku kidogo, but go ahead and check. Are you seeing more of those individuals?
Yes, so there are several factors. Actually, you did a good poll, and that is, in science, we would say that you did a test on saying factors that affect testing, self-testing for COVID-19. And there are several, and human beings are clever. They observe what is going on around them. So some of the measures that had actually been put in place as a result of a positive COVID test, and some of the stories that were coming out of some of the people who are being, in quotes, managed for COVID-19 were people were looking at them and saying, no, I don't think. And that is exactly one of the factors that would affect a testing. So someone in his head is thinking, so if I get a test, then I'm positive, what will happen to me? Then they look around and they see some things, not so nice things people are saying about it, then they are unlikely to go for a test. This concern has also come up among health workers who are saying that they are actually at risk, but what measures are being taken in place to ensure that when someone is positive, then their management is decent, their management is not as described. On the flip side now, you would want to say that even if I fear the test and suppose I am positive, and I don't go for a test and I'm spreading it around, what is the effect on me and what is the effect on the people I am interacting with? You may say ignorance is bliss, but in this case, ignorance may not be bliss. Ignorance may mean that you transmit the disease to someone else who then gets an adverse health effect, and you blame it on yourself later by saying because I was fearing the test. So it is in the interest of everyone to ensure that the pathway after a positive COVID test is nice, is well documented. People know that, yes, after I get a positive test, I will, this is what will happen to me. I will be put, the isolation places that may be present are decent. The people, I will be allowed to do A, B, C, D, and it is in the interest of the community for me to get tested. So community education, probably, which you can take up, is very important, and also giving the government advice on what they should do. A lot of the quarantine facilities were initially ish, and that's why some people were even being given an option of paying for theirs. But again, when you give them an option for paying for theirs, you're removing a bit of money from their pockets when you should have, in quotes, sorted that out. So some of the issues are being addressed, and Kenya Medical Association has actually given advice to the government on several things. You saw the other time when people are being forced to pay, the advice to the government is that the people did not choose to get the disease, pay for them the quarantine facilities, so that the payment does not become a barrier to testing and stopping the spread of the infection. Ensure that the places they go, there are infection prevention practices where people can bathe separately, live separately, and ensure that people are not retained because they have not paid a bill or something like that for a disease that is not theirs. We are going further into trying to give recommendations on what is called home-based care. Home-based care, where some people think that they can actually do isolation at home. And some of these policies have actually been put in place. And where isolation cannot be put in place, people are making recommendations of community isolation centers. For instance, if there was a place in Kibera, for instance, where we are saying this is the Kibera isolation center, so that people do not have to move very far away from their place, which is catered for, and people who are tested positive can actually be put in there to recover, so to speak, and avoid spread, then those are some of the measures that we encourage testing. County governments have been urged also to set up isolation centers in their own areas, because initially the only isolation centers were in Bagathi, Kenyatta, and Kenyatta University Teaching and Referral Hospital. So when you have county governments setting up these isolation facilities, people may actually take up the test. The other thing is that we are discouraging the police from using quarantine as a punishment, you see, and that only means that you actually discourage management of the infection, because now it is thought of as like a punishment. And yet, if you put people in quarantine as a result of punishment, you may increase their chances of actually getting the disease. So all these things sorting out will help people accept testing, and they will willingly go for testing.
Doc, you've made mention of health workers. And I also again refer back to the dailies and a conversation that was being shared concerning PPEs. Where are we on the care for all our health workers? Because I like to believe that as of now, we are not swamping healthcare services and healthcare service providers with too much traffic. But does that mean that the health workers who are at the very front line, the health workers who have to deal with the cases that have tested positive, how are they faring?
So there are various levels, and we'll start with the end. When someone tests positive for coronavirus, SARS-CoV-2, so to speak, then the management plan so far is that they are taken to an isolation center. An isolation center is where they are positives, and they are kept there until they eventually turn negative, and then they can be released back. So the isolation centers, in terms of personal protective equipment, they must be there at the highest level. They use level 3 of the WHO personal protective equipment scale, where it's the hazmat suits plus gloves and all the other PPEs that are there. And currently, the KU, MTRH, and the suits are available. If there are any shortages, there would be on and off, but they are actually managing the patients there, and the PPE is available at those levels. At the lower levels, there are levels like district hospitals or county referral hospitals, where you need the health workers to have specific masks, like surgical masks and N95. And recommendations have been made on what the personal protective equipment should be. And various hospitals across the countries are at various levels of having the PPEs. And in a report we had recently, the PPEs may be up and down, in and out. So 1 week they are there, then another week they are not there. So it is up to the procurement teams of this hospital to ensure there is a continued supply of the personal protective equipment. And just for clarification, personal protective equipment include masks, they include face shields, they include gloves, and for places where you actually may be in close contact with people who actually have COVID-19, then the hazmat suits. A development in the country is that now local manufacturing has taken stock, and the hazmat suits and other personal protective equipment are actually now being produced at within the country. Previously, all of them were actually imported. And this is a good development because shortages come as a result of import issues, lack of money to buy the import issues. The manufacturing of personal protective equipment is a good thing. It has provided work for the local industry, and it has made sure that probably in future there will be no shortage of this. Our role as healthcare providers is to ensure that the quality they produce is up to standard. Initially, we had done a few tests on them, and we were seeing maybe they were below standard, but there is a system of continuous appraisal of the same, both at by the health workers and at the Kenya Bureau of Standards. So it's a good development. The PPE availability is improving, but it is up to the individual counties and hospitals to ensure that health workers are protected. It's also important for the health workers to ensure that they demand for this protection, because there is no emergency in a pandemic. When you are if you are not provided for with the adequate personal protective equipment, then the Occupational Health and Safety Act allows you not to get involved in a dangerous situation just because the authorities have not provided. It is dangerous for health workers because they usually think they need to save the life and they jump in, but it can also be a danger to themselves. So they must also keep demanding for personal protective equipment.
All right. Now, you've spoken about better understanding, more knowledge, better quality in terms of PPEs, better systems of care as well, which leads to better information. What new understanding do we now have concerning the coronavirus? Because it's been several months now. Talks of a vaccine, obviously, that's still probably years down the line, months down the line. But what new information do we have now that we didn't have then?
Information that we have about coronavirus, COVID-19, is information collected from everywhere that the COVID-19 has left its mark. We started with Wuhan, China, and then China in general, then it went to Europe and in America, and now in Africa. The first thing is that the virus has actually been defined genetically. And that was a start. By January, the Chinese already had the genetic makeup of SARS-CoV-2, the virus that causes coronavirus. So that was a plus. And when you have the genetic makeup of it, the genome allows you to be able to actually start the manufacturing of a possible vaccine because you know what the genetic markers are. Also, the genome has allowed ability to test. The PCR test that is being done is because they know the genetic makeup of the virus. So that has been there. So we know the genetic makeup of it. About the transmission, we have learned a lot from China, Europe, and USA, and also in Africa. And we've seen that, yes, it's passed by aerosol. And that's why some of the recommendations being done are like masks, for instance. When they prevent aerosolization of your secretion, so to speak, then that reduces transmission. And some of the recommendations coming out are as a result of this. We have also seen still that the viruses can stay on surfaces, which when touched, then you touch your face again, you can transmit the virus. These are all lessons that we sort of had before. What we are now looking at is we had one of the lessons from the virologist and saying we do not know whether the strains coming to Africa are different from the ones that were in China, are different from the ones that are in US. And a virus, if a virus strain is different, you want to see about its infectivity. That means how fast, how many people does it infect, and how lethal is it. So there are still those studies going on as to try to check, and I'm sure you've heard some of the stories that, oh, maybe the strain in Africa is weaker. We hope so. And those are the studies that are still going on. The Kenya AIDS Vaccine Initiative, CAVI, at the University of Nairobi, has been taking the lead in actually studying this virus, and more and more information is actually being accrued on it. But on the basics remain the same. How to prevent transmission remains the same. Avoid aerosolization, social distancing, and those are the ways the knowledge actually has been relatively the same from the beginning.
Okay, all right. Doc, in closing, your thoughts on staying safe, your words of advice. I know at the end of this week, Kenyans are optimistic and some are holding their breath and hoping that this limited movement may be lifted so that we can maybe go to discos because their birthday is coming up for certain people. Let's not mention names, but there's a lot of expectation. There's hope for people to resume their normal life. And whether it's lifted, whether it continues, what are your final thoughts on staying safe in this season?
Yeah. So what we need to know is that the scientists are on it, and the recommendations being made by the medics generally should be followed. Medics basically operate on data. So we would want to know, it is the data that will direct what will happen next. And one of the things that we have asked for is testing, especially in areas where we think that there may be a high caseload of that, but we also want to get the point prevalence, meaning that in this whole country, is the COVID-19 everywhere, so that we can make our recommendations based on science. So the first thing we would encourage is that the government ups its testing. If, for instance, we could do tests on all 47 million Kenyans, we would actually open up, knowing that in this place we have 4 positives. But what is taking us back is actually the lack of accurate information. So our biggest investment, so that we go back to our partying and birthdays, is actually in information. If you can know where this disease is, who is positive, then you can actually open up with information. But whilst you don't know, then it becomes very difficult to open up. And of course, the big debate is about schools. And schools would be a big source of transmission, let's say. Suppose, and the big issue is, so we would need to know how dangerous is it to open schools by knowing who is positive, who can be treated. And more importantly, is that because our biggest fear of COVID-19 is that the healthcare system is weak and might not support someone who gets infected and needs it, then we must all advocate for strengthening of the health system. And strengthening of the health systems, including training and retaining qualified health workers. And as an association, we have asked for a health service commission to do that. It includes equipping and building more hospitals, ensuring that they run, and more important, ensuring that public health works. And we urge Kenyans to stay safe, maintain social distancing, wear their masks, and listen to their healthcare providers, and listen to your show, I suppose.
Wait, did you hear that plug? Dr. Simon, it's always wonderful to catch up with you. We continue to remember you, members of the association, and everyone really in the medical field, because you are in the front line, your support staff in the hospitals and the centers as well. Tunawakumbuka wote. Thank you so much for making the time to speak with me. I look forward to catching up with you in the not too distant future, where we can all sit down and have a glass of wine, enjoy the birthdays, take the kids to school, and just get back to a new normal. As always, please remember to click subscribe and hit notifications so you never miss an episode when we upload. I'm grateful that you've caught up with us on this episode of Sheila Lives Out Loud. Remember to stay safe and share this video. If there's something you've learned and you want to share it with somebody who is in the medical field, who's just taking things a bit too easy, please share this video, drop a comment below, and I look forward to catching up with you again for another episode next week. Until then, live out loud in all that you do. Goodbye, Dr. Simon.
Thanks.
Bye.